Okay, we are recording. There we go. Hello and good evening, everyone, and welcome to the Voice of Lupus Foundation's educational webinar series entitled, There is Us in Lupus, Take Charge. Today, we are discussing lupus and the kidneys. This session is being facilitated by the esteemed Dr. Shaun Lynch, Consultant General and Transplant Nephrologist attached to the Eric Williams Medical Sciences Complex in Mount Hope. He is also a practicing doctor. He is, sorry, I should say that again. He also holds practicing privileges at numerous private hospitals after completing his undergraduate and internal medicine training in Trinidad and Tobago. He did a double fellowship in general nephrology and transplant nephrology at the University of Toronto in Toronto, Canada. His interests include kidney transplantation as well as, I hope I get this right, glomerulonephritis, including lupus nephritis. He is a fellow of the Royal College of Physicians of Edinburgh and a member of the American Society of Nephrology. Now, some of you might be asking, well, what exactly is a nephrologist? Well, a nephrologist is a type of doctor that specializes in diseases and conditions that affect the kidneys. Most of them, they work to treat conditions such as chronic kidney disease, kidney infections, and of course, kidney failure. It is said that almost 1/3 of those diagnosed with systemic lupus erythematosus could develop lupus nephritis and other kidney-related disorders. And that statistic is being quoted by the Lupus Foundation of America. Now, when lupus attacks the kidneys, the damage can be life-threatening. Now, this webinar series is aimed at identifying kidney involvement in lupus very early, treating it aggressively to stop this damage in its tracks, essentially. Now, having an unpredictable and debilitating disease like lupus can be very challenging and, of course, overwhelming. At the Voice of Lupus Foundation, we have always been here to offer our support to lupus patients all across Trinidad and Tobago. Now, our aim for this educational series is to connect people with lupus to important resources that can help them learn the skills that they'll need to manage everyday life with living with this disease. Now, please note, this is a very interactive session and we implore all of you to send your questions so that we can engage Dr. Lynch. Now, a little background on lupus. Lupus is an autoimmune disease that can affect almost any part of the body, most often joints, skin, kidneys, heart, lungs, blood, and the brain. Today, my brain has not been functioning well. Ask Dr. Lynch, he can tell you about that. I'm just kidding. So you have 2 kidneys, and that makes up your renal system, which is also including the bladder and some other words that I am not even going to attempt to pronounce at this time. So the primary organs of the renal system, your kidneys, are responsible for maintaining the correct amount and type of body fluids, removing waste products and toxic substances, as well as regulating the hormones. Those are chemical messengers that help control blood pressure and, of course, blood volumes. I hope I'm going right here. So without further ado, it is my pleasure to introduce Dr. Shaun Lynch. Dr. Lynch, welcome to the Voice of Lupus Foundation.
Thank you, Reeanna. And thank you for the Voice of Lupus, but you've preempted everything. You gave quite a good introduction, with regards to basically what lupus and kidneys do, and we can move from there to see what happens when the lupus affects the kidneys, actually. One thing I would say, they quoted 30%, but it's probably a much higher percentage than that where lupus affects the kidney. And that's because, in a lot of patients, it may affect it to a degree that is mild, that it's not identified or picked up readily. But some people will quote up to 50 to 60% of patients with lupus will have renal involvement or kidney involvement.
Well, I very much was excited. I mean, you were, apart from Dr. King, when I had reached out to her, you were the second person on my list because I felt that lupus nephritis needed to come out of the shadows because we needed to have that discussion because a lot of lupus patients, especially those who are diagnosed with systemic lupus, the biggest concern is organ failure. Especially
Yes,
with the kidneys, you know. So
yes.
I'm so happy that we can facilitate this session. And I know that there are a lot of lupus patients logged on who have questions. So I guess the first question off the bat would be, can you tell us exactly how does lupus affect the renal system?
Okay, so that big term called glomerulonephritis, it's a big term that really means inflammation in the little filtering units of the kidney called the glomerulus. And that's how lupus affects the kidney. The thing is, lupus could affect the kidney in different ways. And therefore, the only way we could know how lupus, well, before I go into that, one of the ways that we could tell that lupus is starting to affect the kidney is if you start to have abnormalities either of your blood test for your kidney function. The most common blood test that we do to look at kidney function is called a creatinine, or, and very importantly, whether you're having abnormalities in your urine in terms of blood and protein. And oftentimes, that's where things are missed. So oftentimes you will have patients who will have a normal or close to normal serum creatinine. The doctor may look at it and say, hey, your kidney is functioning okay, but that's not exactly true, because if your creatinine is normal, but you are having a significance of blood or protein in the urine, blood and protein are not supposed to be in the urine. And those are some incipient signs that lupus is affecting the kidney. So
Right.
usually that's how they would come to attention. Either someone has picked up that someone has an abnormal large amount of protein, or they're having recurrent amounts of blood in the urine,
Mhm.
or that their serum creatinine, which is a blood test to look at how well the kidney is filtering, is elevated.
Would you share that this common, I don't know if it's a misconception or a myth, but is kidney disease is it a silent disease?
Very much so. So that's one of the problems with kidney disease. It's less so, I would say, in lupus, because lupus is usually presents itself. So with lupus and kidney disease, if you're having protein, you tend to have a lot of protein, and therefore you tend to swell. And that usually is what brings the patient to the attention of the doctor. Hey, doc, my ankles are swelling. What's going on here? This never happened before. But generally speaking, kidney disease is or could potentially be a silent disease. In other words, you could be losing a lot of kidney function and not feeling ill. And that's a problem, because when you have a symptomless disease, the way to pick up or to follow a symptomless disease is to screen. So in other words, you know that this person is at risk for kidney disease. They have lupus. If you have lupus, you're at risk for kidney disease. And therefore you are supposed to be screening for it. It's really unforgivable for patients who have lupus that they are not being screened for kidney disease. And I can't emphasize the importance of not only doing a blood test. This is the problem here a lot of times. Patients will do the blood test or will be sent for a blood test. Their creatinine will be okay. And they'll say, oh, it's fine. No, it's not fine. They could have a lot of protein or blood in urine, which is indicating that the lupus is very active in the kidney. And we know it's only a matter of time before that creatinine starts going up. And you want to catch this disease as early as possible to try and preserve and to save kidney function. So it's really unforgivable that patients with lupus should not be screened for kidney disease with both a blood test and with a test of the urine, either a urinalysis, where we could look at the urine under the microscope, or where we could actually check for the amount of protein in the urine and look for blood and all these things. Those are the two ways that we screen. But it's definitely a symptomless disease. When you
Why?
start developing, sorry.
I'm sorry, you go ahead.
So, and I mean, I give this talk all the time because it's my pet peeve. When you start developing a lot of symptoms from kidney disease is often when it's quite advanced. And
Yes.
that's not the time you want to be intervening. You want to be intervening in the early stages, because oftentimes when it's quite advanced, the damage may be irreversible to the kidney. And therefore you're looking at either dialysis or you're looking at a kidney
Kidney
transplant.
transplant, yes. My question, I was going to interject there by asking, you mentioned that, the criteria in terms of the testing, usually checking kidneys are not one of them. How can we change that as an NGO that's, so health bent on creating change and advocating?
Testing kidneys is definitely one of them,
Yeah.
because renal involvement forms part of the criteria for lupus.
Yes.
And the only way you can look for renal involvement is to look for renal involvement, which is to check for the kidneys. So,
Yes.
so definitely, without doubt, screening for kidney disease and lupus, it's really, second nature. It should be done. It's just like doing a blood test or a blood count, or it's that important, very, very important, and can't be missed or can't be left out.
Right. Lupus is such a complex disease in that, it mimics so many other things. And then no two
Yes.
lupus patients are identical. We share
Agreed.
commonalities with our illness. However, each individual case is somewhat unique. What would you agree that, most patients who are diagnosed with systemic lupus develop some sort of kidney involvement throughout their diagnosis? And what is
Yes,
what's the percentage?
they would definitely, as I said, up to about 60%. Now,
60.
the thing with lupus, I agree with you. Sometimes you have, because you have this criteria to fulfill, and oftentimes all these things don't happen at once. So somebody might have low platelets 2 years before, and then they develop joint pains, and then a couple of years after they have a rash, and then finally the ANA turned positive. Well, the one thing with kidney disease is that when you develop kidney disease from lupus, the lupus usually declares itself. So it's not the patient who's been looking for a diagnosis for a couple of years and we're not sure and they're not quite with the lupus criteria. By the time it presents itself in the kidney, the lupus has usually declared itself. Also, to define the type of disease of the kidney, because lupus affects the kidney in different ways, we would often do a kidney biopsy. And a kidney biopsy, oftentimes on its own, with just a couple other symptoms, could make the diagnosis of lupus, because there's certain things that we would actually see in that biopsy when we look at it that is classic for lupus. So fortunately for me, oftentimes it's quite easy to make that diagnosis of lupus nephritis or lupus affecting the kidney, as opposed to the rheumatologist like Dr. King. Oftentimes you may not make that diagnosis of lupus for a couple of years because they have these symptoms that present at different points in time, and you're not quite there yet because you have to meet this criteria for lupus. But for me, it's kind of easy. Once it's there in the kidney, it's usually there to diagnose of lupus, and we move forward.
Just for the interest of those who are not lupus patients, but they're looking on, can you explain what lupus nephritis is?
Well, essentially, it's lupus affecting the kidney. Lupus is a chronic disease that waxes and wanes, body attacking itself, multi-symptom, multi-systemic, I should say. And one of the systems is the kidney. And when it attacks the kidney, we call it lupus nephritis.
Right. And not all lupus patients develop lupus nephritis, but they do develop other other kidney complications. Can you expound on that?
Well, usually not. I mean, if you are a lupus patient and you develop kidney disease, it's usually lupus nephritis. I mean, anything is possible. I mean, you could have lupus patients who develop diabetes because of steroids or whatever, and then the diabetes could affect the kidney. Yes, that's possible. But usually, once you are a lupus patient, and I mean, medicine usually follows a pattern. Things aren't very complex most times. They're usually simple and they're usually straightforward. And almost certainly, when you have lupus and you have kidney disease, it's lupus affecting the kidney. I mean,
Right.
rarely would it be you have different sort of disease processes happening in the same individual. Usually we're able to tie everything into one.
Into lupus nephritis. It's under that. Right. Okay. Now let's talk about the treatment. So let's talk about a lupus patient who, had no symptoms, but routine check started to show. Like, for instance, I remember a couple of years back, they started seeing protein in my urine. However, it
Yes.
was not like alarmingly high. I believe it was 2 or 3 plus. That was Dr. Punkin when he was at San Fernando General Hospital somewhere around 2011. But my functions blood-wise was okay, but there was some protein in the urine, but it went away apparently.
Right. So this is the thing. So 2 and 3 plus is not acceptable. 2 and 3 plus is acceptable for the office as a screening test to say you have protein. It's either very little, a medium amount, or a lot. That's what a dipstick test does. What has to follow, what absolutely has to follow after a dipstick test is what we call a quantification test. We have to know how much protein there is because how much protein there is matter. It's a huge difference if you have 100 milligrams or 10,000 milligrams.
Wow.
That tells us something. So it's not acceptable, and I see this all the time, when patients don't have their protein quantified. You should have that screening test in the office. That's good. We dip your urine. We say, there's protein here. We now send you to the lab to do a formal test to measure out the amount of protein in the urine. That is the most important thing that has to be done because it is not only helps us to diagnose, but it helps us to follow the course of treatment. Because let's say we're using the amount of protein in your urine as a marker of the activity of your disease. If we treat you, we expect that that goes down. And therefore, we use the amount of protein in urine as a marker of response to treatment. So what should happen is after you do that dipstick test and they test the amount of protein, then when the amount of protein comes back based on the result, you should have a kidney biopsy. And I need to emphasize this, very important. You should have a kidney biopsy. Different nephrologists use different thresholds. My threshold is about 500 milligrams on repeated testing. So sometimes you may have a little bit of protein for whatever, you may have a little infection, but you want to repeat it and make sure. Let's say I do it once and it's 5,000. Well, I don't need to repeat that. Yeah. but or you can have more than that. I have patients with 20 grams, 20,000 milligrams, 30,000 milligrams. Yes, you get that. But when you have that lower spectrum of about 500, 1,000, I used to biopsy at 1,000. I've kind of gone down to 500 now just because of latest updates and guidelines and stuff. But you must have a kidney biopsy. Why you must have a kidney biopsy? Because the lupus affects the kidney in different patterns. And we use a specific classification to classify how lupus affects the kidney into class 1, class 2. Now, class 1 and class 2, you usually wouldn't see. Why? Because they wouldn't present. A class 1 or class 2 lupus wouldn't have a lot of protein, will have very, very minimal or none or no blood and a normal creatinine. So that patient, you usually wouldn't biopsy because they wouldn't meet the criteria for biopsy. But occasionally you may biopsy and you may see a class 2. So they have class 1, class 2, class 3, class 4, class 5, and then there's a class 6 in the newer classification. Now the confusing thing, and I didn't make this up, this is just how it is, you may think that as you go up in class, things get worse. And that is generally true, except for class 5. So class 5 lupus actually has a better prognosis or better long-term outcome than a class 4 or class 3 lupus.
Wow.
So again, I didn't make it up. They just want to confuse you some more. And the class 6 lupus, which is on one sort of grading criteria, not on another, that's just a kidney that's gone. Dialysis time, transplant time.
Right.
So sometimes we don't talk about that. Usually we don't biopsy that kidney because we recognize that that's probably irreversible. So the first thing is you pick up either high creatinine and or lots of protein in the urine. Usually not just blood. Usually if it's just blood, we know there's some activity there, but it's not a lot because it's the protein that really drives the effort to biopsy this kidney.
Right.
So you repeat it. If it's very high, well, boom, that's it. You need a biopsy one time. If it's kind of the lower range, sometimes I may wait because sometimes it may go away. Sometimes I may wait. Sometimes I may give some drugs that reduce protein by not affecting the immune system. And then I may repeat it. But if it's persistent, And as I said, I used to use a gram. Now I've come down to about 500
500.
milligrams.
Yeah.
Then I would biopsy the patient as well. And then once I biopsy the patient, then I have a picture of what is going on in the kidney rather than using a marker of what is going on in the kidney in terms of blood, protein, and creatinine. And then once I have that picture and we classify them into the different classes, then I can have a discussion with the patient about treatment, but also prognosis. Prognosis is very important. You know, sometimes you look at values and then when you look at the biopsy looks bad. You know, there's certain things we look at, but the numbers may not look too bad. But when you get that biopsy and you look at it and you say, oh my goodness, this is a very active, we'll say active lupus in this kidney, you know, you have to have that discussion with that patient because not because we pick it up and we have treatment options means everybody would respond.
Yeah. What I have found in terms of being at the helm of interacting with so many patients on different levels, a lot of patients complain that in the public health system, sometimes their experience is that they are unable to really have that one-on-one time to really discuss things thoroughly with their doctors. Because in the clinic
Yeah.
setting, you know, it's a kind of like, okay, next file, you know, move along, move along.
Uh,
So in terms of, you know, this forum, in terms of trying to educate patients about what are some of the telltale signs physically, if any, that, you know,
yes.
that warrants them saying, listen, doctor, this is what I've been experiencing. Can we check? Can we do this?
So as I said, every patient should be screened anyway.
Yeah.
So even if a patient says they're feeling great, they could run a marathon, they have no problems, they should be screened.
Yes.
But the most common symptom is swelling because of the protein in urine. That's far, far, far the most common symptom. But I want to say something with regards to the clinic, and I agree with you. Listen, I used to have 50 patients booked for my clinic. There's no way I can see 50 patients. However, there are some patients who absolutely need my input. So I would have junior doctors, and unfortunately, junior doctors don't know everything. They don't have the experience, they don't have the training, but I can't see 50 patients by my own. And if I see 15, which is how much I could see, then everybody will start a cuss that they're waiting 3 years for an appointment. So we book the clinic. But what I have done, for instance, in my clinic, is that there are certain diseases that I have to see the patient, or at least my input has to be there. And certainly lupus is one of them, or other glomerulonephritis.
Yes.
Now, you may have the patient with a little bit of diabetes and some kidney disease. Well, you know what? They will see the junior doctor. I'm sorry, I can't see everyone. But you bring up a very important point that people who have these things like lupus nephritis, they need that specialist input. They absolutely need it. They can't just be getting some kind of wishy-washy, halfway kind of thing. Because not only is the disease bad, but also the therapy that we use to treat the disease could potentially be bad as well. Immunosuppressive drugs have very bad side effects. I've seen some of the worst infections with immunosuppressive drugs. So you have to know and you have to balance that. You have to strike that balance between getting the disease under control with drugs that could potentially have their own bad effects, and also the disease itself, which is in itself bad. You try to strike that balance all the time. So usually, to be honest with you, most of my lupus patients, I can tell you what's going on with them. I say, oh yeah, she was there, she had this, that, this happened, blah, blah, blah. Because I insist and I make it a point that anytime a junior comes to my clinic, I see all the lupus, or you could see them, that's okay. You can talk to them, but I have to at least have a little discussion with them, or if not, see them myself. Most times I've seen them myself so much I know them. I just go say hi, bye, how everything, things look good, you're great, we see you next time. Or if there's an issue, we deal with that issue.
Yes.
But I agree with you. There are certain patients who are being failed within that public healthcare system of too many patients, because one consultant and 50 patients. There's no way you can see everyone, but there has to be some system where they don't fall through the cracks.
Well, I hope this educational series will be the start of something that could potentially help them at least understand and get in the know in terms of understanding the illness. Because what we found is that even lupus patients themselves, they don't even understand their illness. They don't even understand what to expect or what they're dealing with.
I should also mention that as Dr. King is here, we've also spoken about trying to do a combined clinic. And
Trying to do
this certainly a combined rheumatology nephrology clinic.
right, that would be great.
So you know, and that model, where I trained, that model happened. There was a combined rheumatologist. So you had a rheumatologist and a nephrologist there who would both see the patients. You know, we tussle and turn and disagree a lot of times, but it's good. Different perspectives. And looking, and we've talked about that. We probably haven't gotten it wrong. You know, there's issue with clinic space and what have you.
Of course.
But we've spoken with that just a few weeks ago about
Well,
trying to
maybe this is
establish.
something that Voice of Lupus could probably think, because we were supposed to launch the Lupus Learning Resource Center.
Yes.
However, with COVID, and then I went through some personal loss with my dad, so everything just got put on hold. And then coronavirus took over, and then being stuck over here, I can't. There's only so much I can do now. The office remains closed, so maybe that's something that we can look at, and offering it. Maybe I'm looking at the best price, which is free, but I know definitely that may not work, all the time. But
I mean, it will
we
be
can
a
look at.
fantastic thing because it will be exclusive to patients with lupus nephritis. So
Exactly.
that's all you're dealing with. You're not dealing with the diabetics, the old lady with high blood pressure, that man with the prostate who creatinine up because of that. So you're dealing with and usually these are young patients. So these
Yeah,
are patients that
that
we
brings me
have
to my
to
next
invest
question. When
in.
you're finished, have you seen an increase in the number of young cases with lupus nephritis now? Because there was a patient that came forward, I think it was 5 or 6 years old.
Well, we won't see those cases. Those will go to pediatrics.
Pediatrics, okay.
Yeah, because of the age. The only time I would see them is if they have kidney involvement, because the pediatric doctors, at least some of them, would ask me to get involved in the case. Well, we now have a pediatric nephrologist, so she has sort of taken over, because for a long time we never had. So us adult nephrologists, I mean, we had nobody, so we would used to offer. I mean, it's not a difficult thing. I mean, the issue with the pediatrics more oftentimes is the anxiety of the parents, really more than anything.
Yes.
But we used to cover them. But now there's a pediatric nephrologist. She has directly taken over that role. So we won't see those younger patients. They would go to pediatrics, and she would probably see them.
Mm-hmm.
But we used to see those younger patients before she came. I can't really say if there's been an increased incidence. It's difficult to say. I've never really studied it. What I can say is that we have a lot of lupus. I mean, it's common, especially in dark-skinned individuals, of which most of our population is.
Mm-hmm.
And we have a lot of lupus in Trinidad. And we have a lot of lupus nephritis in Trinidad.
Wow.
And we have a lot of people ending up on dialysis because of lupus nephritis in Trinidad. So we do have a lot of work to do. I think we have improved, to be honest with you. I think we have improved a lot from where we were. Our human resource is better, I would say, because we have far more nephrologists now, people who understand lupus, rheumatologists, where we were lacking in human resource before. We now really have available medications as well, because I mean, a lot of these medications, they're not cheap.
Yeah.
So I think we've advanced and we've progressed, but there's always so much more to go.
Yeah, we are actually on the same wavelength, because my other question would have been, is there a higher prevalence of lupus nephritis among specific racial or ethnic
Yeah,
groups
definitely.
in and Tobago? And if you could have listed who those groups were.
So if you look at lupus worldwide, lupus is far more common in the United States and in African Americans and Hispanics.
Yes.
And it's usually, and the problem with how they class Hispanics in the US is they could class Hispanic white, Hispanic black. It's usually Hispanic black.
Yeah.
So for sure, it's far more common in people of recent African descent. And we also see it in our East Indian population in Trinidad as well. So we have the population where we get lupus, and it's far more common in women as well than men. Unfortunately, when men get lupus, they tend to get it worse than women. But it's a disease really of young Black women. That's who tend to get lupus more than anything else.
Yes. We talked about, so much, but what about the treatment? Can we delve into the treatment of lupus nephritis? You talked about
So
immune
yeah.
suppressant drugs. Can we discuss that?
So once you develop lupus nephritis, then that's considered an organ threatening disease. You've developed lupus that is affecting an organ. Usually the other organ it will affect is the brain. You could get inflammation of the brain and different things in the brain, but the kidney is the other organ. So if you have organ threatening disease, you can't fight a war with a pistol. So you need to fight with big guns. So usually once patients develop lupus nephritis and we would do a biopsy and we would see a lot of inflammation, then the first standard thing go to is steroids. And we use high doses of steroids. Sometimes we would bring them in, give them in, and most times actually intravenously, methylprednisolone, big doses. And then we taper from there.
Mhm.
And steroids are great drugs. Steroids would have been the best drugs in the world if it didn't have any single side effect. I swear to God, they would be the best drugs. But unfortunately, steroids have a lot of very bad side effects, and we all know about them: the weight gain, the hypertension, the thin
Yeah.
skin, the susceptibility to infections, um, diabetes, bringing on diabetes. It could affect people's mood. I've seen people who come in psychotic and they think they're mad, and it's because they're taking steroids. And it's the steroids that affected their mood. Some people get depressed. Some people get psychotic. So steroids have a lot of side effects. So we understand that we cannot ever maintain a patient on high doses of steroids for a prolonged or indefinite period of time. But
Mhm.
we usually would give that high dose of steroid to get that inflammation down in the kidney. And then what we would often do is have a second agent. And the second agent is meant to keep the disease in remission without using steroids. Because once you have disease in the kidney, that's considered a flare. We try to get you down and get you into what we call quiescence, where there doesn't seem to be any activity in the kidney. So steroids first up, and then you have the second agent. And out of those second agents, we have drugs such as cyclophosphamide, which unfortunately people have given a bad name, but it's still quite a very good effective drug. We have things like mycophenolate mofetil, commonly known as Celsep.
Yes.
We have drugs like azathioprine or Imuran. And methotrexate, more so we used to use that. We don't use methotrexate anymore in kidney disease specific lupus. It may be used for other forms of lupus. If you have lupus mainly affecting the joints and stuff, methotrexate may be considered, but methotrexate has gone out of vogue rarely in lupus nephritis. Plaquenil is always used.
Hydroxychloroquine.
I don't really include Plaquenil in the big guns. Plaquenil is more like a pistol. It helps. So it does help if you look at the data. It does reduce some flares, but Plaquenil is not going to take you down when you have 20 grams of protein down to normal. That's not going to do that.
Yes.
But we always throw it in there because there's some data that it reduces flares.
Yes.
So it's not really used to get that inflammation under control, but is used to reduce flares. Because the one thing is you can flare and have a bad a lot of protein and we can get you down, but this could happen again in the future, and we're trying for that not to happen. And that's really it. And the choice of therapy really depends on. I should mention rituximab as well, which has also come into vogue with lupus nephritis. That's another big one, I would say. And the question of which therapy you choose. I mean, steroids is a standard therapy. Everybody gets steroids. And then what you choose after that really depends a lot of times on the patient, uh, desires, how bad the flare is. Oftentimes, I would consider what the biopsy shows. If the biopsy looks really, really, really bad or not too bad, the age of the patient, if the patient have gotten previous therapy, has the patient gotten a lot of cyclophosphamide in the past?
Yes.
All these things that we have to consider before we would give a drug. But most times it comes down to a choice between Celsep or mycophenolate mofetil and cyclophosphamide. And again, each physician will have his own view. And part of the reason for that is because most of the studies shows that these drugs are equivalent, they're equally effective. And also people have their own bias. Everybody has their bias. Well, where I trained, we use this more, so I tend to use this. And also too, you have to understand that, if you do a cardiovascular study, if you do a study of heart disease, these people enroll 20,000 patients. You do a lupus nephritis study, you have 65, and that's a big study. So when you have such small numbers, when you're studying it, it's very difficult to discern one therapy being more effective than the other.
One of the challenges that we get and we understand with patients is that many patients, it is said that they don't always take their medications according to how it's prescribed. Can you talk about the dangers of not taking your medication as prescribed, especially when there is major organ involvement, such as lupus nephritis? I'm guilty of that.
So I
In the
think
past, I have
before we even talk about not taking the medication, the most important thing is to find out why.
Yes.
So people will say, oh, she's not taking her medication, but she goes to the pharmacy with a prescription for Celsep, she gets none, and then she goes to buy it and they tell her it's $5,000.
Mm-hmm.
Well, she says, well, I'm not going to take that. I can't afford that. Or she might get a 2-week supply from the pharmacy and she has to go back every 2 weeks. And well, guess what? She has a family to take care of. She has work. She can't go every 2 weeks. So she's deciding, well, you know what? Instead of 2, I'm going to take 1. So I'll stretch this thing out. And oftentimes when you dig deeper into why patients not taking medications, it's for this reason. So for me, the first reason I would be like, why are you not taking your medication?
Yes.
Is it because of cost? Is it because of unavailability? Yes, you can. Yes, you can. So that's the first thing. And then the second thing is the side effect of the medication.
Yes.
The most common side effect with Celsep is diarrhea or GI upset. So they take this medication and in the bathroom every hour, and they can't be like that on work.
Yeah.
So they decide, well, I'm not going to take it in the morning before I go to work because I'm always in the bathroom. So we often...
Hi, buddy.
Go by mommy. So
Yes. And that's a very valid point that you raised, because I know that a lot of patients, apart from some of them, they don't want to take it because they're scared of the side effects.
Yes.
Most patients complain about the unavailability of some of the medications in the hospital pharmacies, and it's so expensive to purchase.
It's very expensive. Very expensive. So I think that takes care of a lot of the reasons why people don't take. And the other reason is they're the patient who just like, I'm not going to take this. And that's when you have to get into that sit down one-on-one educational discussion, because organ threatening disease from lupus is bad and it is potentially life threatening. Now, I don't know if it's a good news, but the better news about kidneys is, worst case scenario, your kidneys fail, at least we have the backup of dialysis so that you shouldn't die because of that. Kidney is the one organ, even if it fails, we have a form of therapy that we can keep you alive. Not meaning that dialysis is the be all and end all. It has a lot of shortcomings, but at least there's that backup. So it's not really that they will die if they don't take it. From that perspective, they could get really bad stuff affecting their brain and all of that. Because remember, lupus is a systemic disease. If it's very active in the kidney, it tends to be very active or potentially very active in other organs as well. So when you treat lupus nephritis, you're not just treating the disease in the kidney, you treat the systemic inflammation and you treat the disease. So you're also protecting against the other organs as well. And you have to get that education about how important it is, because again, these are young people, and I've seen deaths from lupus. I mean, we had an unfortunate one recently with quite a young patient.
Yes.
It's very sad, very, very sad. So it's very important that people understand why we give them these medications, that this disease is potentially life-threatening, it's serious, and we have to take it seriously.
What is the expectancy in terms of the years to develop kidney failure when you are diagnosed with lupus nephritis?
So again, different phases, different cases. Each patient is different. A lot of patients present with kidney failure. So they present with kidney disease. So from the onset, they have kidney disease. It's very variable, each patient. There's some patients who have lupus and it's very mild. They may have a little joint pain. We like those people. They have a little joint pain from time to time. They never really fully develop organ-threatening disease. We love those people. Once you develop organ-threatening disease, even if you go into remission, there's always the risk that it could flare again.
Yes.
So we're always worried about that. But time to onset is very difficult to answer, because it's a really individual thing, and no one could predict. I can't predict if you come by me now with lupus that you're going to have kidney disease. Then I have the bias as well. By the time they reach me, they have kidney disease. So I am only seeing these patients with lupus and kidney disease. So I have that kind of bias as well. I tend not to see the lupus without kidney disease. I leave that for the rheumatology people.
Right. I'm quoting statistics here coming out of the World Lupus Federation that said between 10% and 30% develop kidney failure within a 15-year period of their diagnosis. Do you support?
Well, again, that may be in a Caucasian population.
Okay.
Because it's also well known that not only is Black lupus and lupus more common in Black people, but it's also more aggressive in Black people. When you look at studies, so when you study a lupus population in Europe that's mainly Caucasian, you cannot, we talk about this all the time in conferences, you cannot apply that data to an African American or Afro-Caribbean population, because it's well known, even adjusting for socioeconomic factors. There are socioeconomic factors, especially in the United States, with disparity in healthcare access. But even adjusting for that lupus is far more aggressive in a Black population.
Right.
So that may be good for a kind of European white population.
But not for Australians.
But I don't think that applies to us at all.
Yes.
That's like prostate cancer in Black people and white people. It's a different disease.
Wow. Okay. Well, I did not know that, but that's interesting. I'm looking at our Facebook Live here, and someone is saying, they're asking this question: when would you say is the best time to take your medication? Not sure specifically what they're asking here, but
well, again, it depends on your medication. I mean, if you're taking oral prednisolone once a day, take it in the morning, that's fine. If you're taking Celsep, that's usually a twice a day drug, morning and evening. I don't think it's but the drugs we use for lupus, it's far less important with timing and more important with actually taking it. Timing of when you take it is a far less important feature.
Okay. Another question on the Facebook Live. A lupus patient in Trinidad is saying, my doctor says I have class 4, but my kidney functions are always good.
Well, again, how is she judging kidney function? Her creatinine may be good, but if she's having a lot of protein in the urine, her kidney function is not good. Now, I can't judge the individual case.
Yes.
The fact that she knows that she has class 4 means that she was biopsied. The fact that she was biopsied means that she had to have a lot of protein in the urine. Now, the question is, okay, you had a lot of protein in your urine, you were biopsied. What is your response? So if you started with 5 grams of protein in your urine, where are you now? Are you still at 5 grams of protein 2 years later? Are you at 300 milligrams of protein? Are you at 1 gram of protein? That's the important question. And I must emphasize this. Looking at a creatinine alone is not the end all, because guess what? If you have a lot of protein in your urine, it's only a matter of time before that creatinine starts to go up. So you cannot be assured that, oh, my creatinine is 0.9 and my kidney is functioning. But you have 10 grams of protein in your urine, your kidney is under attack. It may look good now with the creatinine test, but trust me, in 2-3 years' time, it will not be the case. And that's why we have to treat the disease. And that is why we have to follow some marker. And usually we don't follow the creatinine, because by the time the creatinine starts to go up, the horse has left the stable.
Yes.
That's why we have to look at the protein in the urine. And that's by far the most important marker that we follow in lupus nephritis.
A patient is saying that they're currently taking CellSup, but they're exploring the option now to probably start using cycloinfusion.
Well, again, it depends. I can't comment on
Yeah.
each individual case, but we do that. We do if we believe that the patient is not responding appropriately to one agent, we may use another. But here's the caveat. The caveat is, again, I can't really know the individual case, and I don't know who's a doctor and who's making these decisions, but oftentimes you need patience. Not because we give you cyclophosphamide IV for 3 months mean that everything is going to go away in 3 months. A lot of times in lupus, it takes time. And a lot of times that second agent, it's really going to kick in months down the line. And a lot of times you just have to have a little bit of patience. And sometimes I know my patients, they're swollen. Oh God, doc, I'm swollen. And they're frustrated.
Yeah.
And they want that instant, boom, give me something, make it go away. And I have to counsel them and I have to tell them, just give it some time. It will go away. Give it some time. Give it a few months. That's just how the disease works. I remember a young girl, she came in, she's crying. She was so swollen. I was like, give it some time, give it some time, give it some time. And she went into remission maybe about 4 months into her treatment. Finally went away. She was happy, that sort of thing. We unfortunately in medicine, a lot of times we don't have a magic bullet.
Yeah.
We don't have that thing that we just hit it to you and everything goes away and everything is okay.
Yeah.
It needs time to get on top of that inflammation. So we do switch from CellSep and stuff to cyclophosphamide, usually if we have determined that you have quote unquote failed or not responded to therapy. But not responding to therapy has to be defined by the time we're looking at. You don't tell me you give a patient a month of CellSep and the protein not going down and you've decided you're going to switch because they failed. That patient hasn't failed. That patient has not had time to respond.
Yes. Okay. Another question from a lupus patient is, should I be concerned that I am frequently showing protein in the urine? What's next?
You should be very concerned. If you are showing protein in the urine, you should be very concerned. You need to have that protein measured out to find out how much milligrams and then possibly have a kidney biopsy. Because if you're having protein in urine, it is likely that lupus is affecting, well, it's unless you have another reason to have protein in urine, if you have diabetes or something, those things could present with protein in urine. But most likely it's the lupus that is causing the protein in urine, which by definition means you have lupus nephritis. So if you have protein in urine, you should be concerned. That is not something to be taken lightly.
A lot of questions come in regarding, is there a diet for lupus? So in this case, eating right for kidney health, is there such a thing?
Nope. Apart from, I would say once you have kidney disease, you should stay away from sodium or too much sodium, too much salt, because that drives fluid retention and swelling and edema. Like they've looked at even lupus or non-lupus patients with kidney disease, whether restricting the amount of protein in a diet will, retard or slow down progression of kidney disease. that's been largely thrown out, really. That's kind of 20-year-old thing. Don't eat meat. That for reasons I will not go into, that's not real. That doesn't really hold. Certainly, if you start to develop advanced kidney disease, then there's certain restrictions you have to look at. I mean, if you're closer to needing dialysis and stuff, things like phosphorus, potassium, even your fluid intake, because if you're not excreting the fluid appropriately, you may retain the fluid and swell up and stuff. But to say if there's a specific diet, not until you sort of start to develop advanced kidney disease. And what we hope for is you don't develop advanced kidney disease. That's our purpose, to try and treat lupus early so that you don't have that creatinine starting to go up and starting to develop advanced kidney disease.
Right. Now that diet with the low sodium, is that called the renal diet?
Well, again, a renal diet is really meant for people with advanced kidney disease, based on what we call their GFR. So I have patients coming in my office, and as I tell people, CKD is a wide spectrum, from very mild to very bad. Mm-hmm. And only when you start to develop maybe less than about 30 mils of GFR, sort of stage 4 chronic kidney disease, do you really start to have to restrict the diet. Because despite you losing so much kidney function, your kidneys are still usually able to get rid of the toxins and get rid of potassium and all that to a certain degree. And I have people come in with very, very, very mild kidney disease, and they're telling me about the leaching their food. And I'm like, no. You are not at that stage. You just reduce sodium. They have 50 mils of GFR, and they are being told to leach foods, and they're miserable because the food is tasting horrible. And I'm like, no.
Oh, wow.
So it's really at the more advanced stages of kidney disease do you really have to go into this so-called renal specific or CKD diet, not in the earlier stages.
Right. We're moving along with another question from a patient who is asking about, if a lupus patient gets a kidney transplant, is it likely to be knocked out again when there is a major flare with lupus?
Excellent question. Yes. So for reasons unbeknown to us, most times, like 95% of times, when patients develop end-stage kidney disease, when the lupus has whacked out their kidney, their lupus just kind of dies out. Interestingly, we don't know, we can't explain. So most people, once they reach dialysis, their lupus kind of go quiet. They don't get a joint pain, they don't get a rash, they be normal. So they go into quiescence. So when we transplant them, it tends not to. It's very unlikely for you to have a major flare in your kidney transplant after having lupus. Could it happen? Of course it could happen. Anything could happen.
Yes.
Now also remember that interestingly enough, CellCept, which we use for lupus, we also use for kidney transplant. So we put patients on CellCept to stop rejection of the kidney when they get a kidney transplant. And we use steroids. So we use some of the drugs that we do use for lupus in patients with a kidney transplant. We use drugs like cyclosporin and tacrolimus, which we may also use in lupus patients as well. So for you to, as I said, so you tend to go into quiescence when you end up with bad kidney disease, and then we transplant you and give you medications that also treat lupus. For you to flare through that, well, boy, your lupus really, really wants that kidney back.
Yes,
so that is very unlikely, and that does not happen a lot. I can't remember the last time, honestly, that I've seen that in a transplant patient. Of course, it can happen. Of course, you have the case reports of it happening, but it's not likely.
Someone, again, they listen to what you just said about the diet, and they're just asking, but are there any foods to eat to heal, to bring about remission?
Well, if there was that, then nobody would have disease, because we would just tell them.
Yeah.
We would just say, well, go and eat, whatever is the superfood of the month. So unfortunately, there's no evidence that there is anything really. Now, I would add, and this came up last conference I went to with regards to transplantation,
Yes.
that the gut, I mean, while we may not have a definitive idea of any food, I don't want to throw out the idea completely, because the gut is an immune organ. It is the largest immune organ we actually have.
Yeah.
And there was some interesting data looking at kidney transplant and the risk of rejection and those things based on foods that people eat because of that gut immune response.
Mm-hmm.
So unfortunately, we don't know in 2020. That doesn't mean that in 2030 we won't know, because the technology and the knowledge is coming about pretty quickly. But we are understanding a lot of these mechanisms a bit more with each passing year. So it may well be that there is some form of diet that may help reduce or keep away lupus. But at this point in time, I can't say that. I can't endorse any diet because there's no evidence of that.
Fair enough. This is a personal question. In terms of you getting involved in choosing this specialty, what drove you to do this?
So that's a great question. So when I first started, I really wanted to do GI. That was really my thing. And then honestly, when I was working in Eric Williams under Dr. Roberts, before Eric Williams became what it was now, when we actually had manageable numbers and used to provide some high quality of care, I saw where all these renal patients would come in pretty sick, and we would do dialysis and they would start to look well, and we would see these people who swelling up and we would give them medications and they would get better. And I sort of got interested in nephrology at that point in time. And certainly when I went away, that was really an experience in nephrology. And and certainly transplantation. So my passion is really transplantation and glomerulonephritis, which is these. And the reason why I like that is because you see the response. I mean, when you transplant a patient and you see the difference in their life, that is really a good thing. I'm not really barking on dialysis, but yes, dialysis may keep you alive, give you a certain quality of life, but it's tough. It's tough. It's a difficult thing. It's really tough. And you don't see that same kind of, smile and joy in the patient as you will see somebody with a glomerulonephritis. They come in, they're swollen, they're miserable, and you treat them and they get better and you see it go away. That's a good feeling.
Mm-hmm.
And I guess that's why I got into nephrology, right?
One of our ambassadors and supporters, Natalie Lagore, she is such an example of strength and resilience. Natalie has to do dialysis sometimes, I think it's 3 times a week. How long can someone, a lupus patient, survive on doing dialysis without getting a transplant?
Well, so as far as I'm concerned, there are 2 groups of people on dialysis. Mm-hmm. There are the older people who will not be a good candidate for a transplant for a number of reasons. Mm-hmm. They're elderly, they have a lot of comorbidities, their heart is bad, they may have one limb, they have bad blood vessels, their quality of life is not really good. And those patients, really, I look at them as we're doing dialysis to just keep them alive, let them have a good final few years, because that's where they're headed. They're not going to be transplanted.
Yeah.
And then there's the other group of patients. The other group of patients is those young patients or even not so young patients who are well and who you should be aiming for transplantation. So for me, a dialysis patient, ultimate goal should be transplantation. Mm-hmm. And you are doing your best giving them great dialysis to keep them functioning, keeping them alive, and keeping them in good health until they get a transplant. The problem in Trinidad and Tobago is we do not do enough deceased donor transplants. And therefore, you have a lot of people ending up on dialysis as their only therapy. And that is a problem, because then they develop all the complications of being on dialysis for a long period of time. So abroad, you would have patients and they would be on dialysis, and they may be on dialysis 3, 4, 5 years, and they would get a transplant. And when they get that transplant, they're off dialysis and their body comes back to what it was before, close to that. We are not having that here. we don't do enough deceased donor transplants for reasons I will not go into, but very frustrating. And we therefore do mostly living donor, which means you have to have somebody to come and give you a kidney. Well, good luck with that. It's very difficult. We may think that people should be easy to get somebody who wants to donate for them and be good, but that's a difficult thing. So we end up with these patients who are on long stay dialysis, which really shouldn't be. And unfortunately, the longer you are on dialysis, remember, you are moving from having an organ that's working 24 hours a day, 7 days a week, to doing a therapy for 3.5 to 4 hours, 3 days a week. It could never replace it. It could never replace it. It could never do what a kidney does. And therefore, eventually, the longer you are on dialysis, things start to gradually creep up. They start to gradually creep up. That lack of having that kidney function every day for 24 hours start to creep up.
Right.
And that's our major problem here. We really should be getting our younger patients, of which most lupus patients on dialysis are well enough that they will qualify for a kidney transplant. The vast majority of them, 90-something% of them.
That's good to know.
But we can't get them transplanted because we do not have either enough deceased donor organs, we don't do enough deceased donor transplants, or they don't have a living donor. So they end up stuck in this dialysis process.
Yes.
And as time goes on, it just gradually sort of slowly eat away at them, I would say. Slowly, because it's not ideal for you will hear people being on dialysis for 15 years. Well, that is not the general rule. That's the exception, really.
Yes.
And they start to develop problems,
Yes. As you mentioned about, not having enough organs and what have you and stuff like that, transplants, donors. What are the top 5 myths about donating a kidney? I know one of them is like, you think I could live with just one? I have 2. Would I be able to live with one?
So let me break it down very easily. If you go in the United States and you go to an insurance agent and you tell them, I have donated a kidney, they will give you life and health insurance, no questions asked. Why? Because people who donate kidneys live longer than the general population. So you may ask, well,
wow,
they just donated a kidney. Why is that? Well, there's what we call a selection bias. For you to have qualified to donate a kidney, it means you are in great health. Not because you present and say, I want to give my kidney, means that we are going to take it. You know how many people walk into transplant and I do a blood test and they're diabetic and I'm like, okay, bye-bye. Not because people present to donate a kidney mean we will take it. So in other words, what I'm trying to say is for you to have reached the stage that you have passed a workup to donate a kidney, you are in great health. And people who are in great health tend to maintain great health. So they tend to live longer. So donating a kidney is absolutely safe from the perspective of donating a kidney, because we don't just take the kidney because you give it.
Yes.
We have to go through a rigorous workup to ensure that it's safe for you to give a kidney, because you gain nothing medically from gaining a kidney. You may gain emotionally from, I give my daughter, I give my sister, my girlfriend, my wife, whoever. Well, it's usually wives give to husband, not the other way around. And I'm serious about that too. That is 100% true. Women will donate to their husbands in the blink of an eye. The converse, well, not always.
Wow.
So you get an emotional effect, but you gain nothing medically. If anything, you lose because you have to undergo an operation. You have to be in hospital for a couple of days. So we are mandated to ensure that it's absolutely safe for you to do this. So we go through a very rigorous workup. We screen. In fact, a lot of people get free medical for coming to try and donate a kidney. They get cancer screening. They get kidney workup. We look at everything. We look at their heart. They get a full screen. So people can feel assured that if they have passed a kidney transplant donor workup, that it's a safe procedure. The Scandinavians probably have the best data on this. I mean, kidney transplants started since the 1950s. They collect, the Scandinavian countries, they are very rigorous in data collection. They have followed living donors for 30, 40 years now, and there's no signal that there's anything that is bad to come of a person who has donated a kidney.
Wow. All right. Well, Dr. Lynch, I know we are wrapping up because you've been here on our chat for about an hour. I'm sure you had a long day.
I enjoy talking.
You sure?
About
okay, good. Because
this is what I live for. This is what I do. This is my passion. I love nephrology. Don't ask me about stroke and those kind of. I love nephrology. This is what I live for. And one of my pet peeves is the delivery of certain cares in Trinidad, and I think that we are not educating our patients enough. Patients are not getting the information. We are failing in certain places, and we should do better. So if this could save one person or educate one person enough that somebody come forward and donate a kidney to them, or they realize that they have kidney disease from lupus and they got therapy that would make it better, then I have more than done my job.
Well, I'm so grateful that you are willing to just, continue being an advocate for us and also for the cause. One patient who's online here asked specifically via private message, are daily headaches a side effect of CellSep?
Not usually. Not usually. I mean, anything could give you a side effect, but I would be concerned if someone having daily headaches, not as necessarily a side effect of CellSep, but remember, CellSep is an immunosuppressive drug. And I have actually seen a case where a patient presented with very bad headaches daily, and what they had was an infection around the brain. A bug called Cryptococcus. It's a fungus. You usually get it in patients who have HIV and stuff, because people in HIV with AIDS, they don't have an immune system. This person didn't have an immune system because we gave them CellSep and we suppressed their immune system. And that person actually started having visual abnormalities after a while. And we actually had to admit them and treat them and all that stuff. So not as a direct side effect of the drug causing a headache, but if someone is having daily headaches all the time, I would insist that they get fully worked up to ensure that it may be a side effect of another drug that they're taking.
Yes.
Or it may be a secondary effect of the drug, not really a side effect, but a secondary. I mean, this is rare, that situation that I just told you about, but I would be concerned and I would encourage them to get sorted out, to at least be assessed. They have to be assessed.
Okay. Well, I would like to extend the invitation to especially two lupus patients who would have messaged and said they wanted to ask you directly a question. Anastasia, I know you are one of them. You can feel free to unmute your mic and ask Dr. Lynch your question regarding, in terms of the treatment. So did you just leave? Oh my goodness, she came off the chat. All right, hopefully she'll rejoin. Alana, do you have a question for Dr. Lynch regarding lupus and the kidneys? You can unmute your mic.
Come out from the noise. Hi, good evening.
Yes, hi, good evening. Hi, Alana.
Yeah. I was thinking, I just wanted to find out, he was talking about the CellSep now, right? Well, I was recently placed on CellSep, and there's a new medication. They had me on the Imuran for like about a month, and after the kidney biopsy, it came back that my kidneys was reading like about 3, and so they switched me to the CellSep and things. So I know I knew what it, I didn't have no side effect from it or anything.
What do you mean by 3? Do you mean that your creatinine is 3?
Yeah. Well, after the biopsy, the kidney biopsy, right? It came back. I think it was 3. They say so. The doctor say, well, 3 not too bad.
Well, no. I mean, I really need to know what this 3 is, because if your creatinine is 3, that's not good. That's bad.
Oh, that's bad.
Okay? That is bad.
But what they were saying,
I don't know if your creatinine is 3, or I don't know if your urine protein is 3 plus, but it's very, or if it's 3 grams of protein you have in your urine. But
it was the protein was 2 plus. It was reading like 2 plus. Yeah, and it normally is read like 2 plus, 1 plus. It varies, you know.
Well, it's very important to find out what that 3 means, and it's also very important to find out. You see, 3. If your creatinine is 3, okay, that is bad.
No, but they didn't give me the impression that it was bad.
I don't know what impression they are giving you, but I am telling you, I don't know what your 3 represents, but if the 3 represents your creatinine, that is not good. That is bad. Now, the question is, why is it 3? It could be 3 because you have a lot of inflammation in your kidney. If you have a lot of inflammation in your kidney, then potentially by treating that inflammation, we can get that creatinine back down to 1 or to 0.9, which is a normal creatinine. A normal creatinine is 0.9 or 1. If your creatinine is 3, that is not good. If it is 3, because you have a lot of scarring in your kidney, because the lupus has attacked your kidney and it's scarred, that is not good, because that means that scarring doesn't really respond to the immunotherapy like CellCept and stuff. So it is very important to define, 1, what that 3 represents. If it's 3 grams of protein, that means completely something different than if it's a creatinine of 3. If your creatinine is 3, that is not good. And I don't know who can tell you that a creatinine of 3 in a young patient like yourself is good. That's bad. And therefore we have to listen. Let me tell you something. You see what you're telling me here is not uncommon. Okay, patients go and they say, oh, my creatinine is 2, and they say that's not too bad. That is bad. If your creatinine is 2, your GFR is probably in the 30s. If I were to tell you, if your creatinine is 3, just off the top of my head, your GFR is probably in the 20s or 30s. If I were to tell you that I would cut your pay by 80%, would you tell me that's not bad? You would be very angry with me. But the problem is that even though your creatinine may be high and your GFR is low, you may not feel sick yet. That is the thing. If your creatinine is 3, it may be, depending on what that biopsy shows. Now, if that biopsy shows a lot of inflammation and we have you on immunosuppressive drug, it is potential that the drug will treat the inflammation and then the creatinine will go down. But a creatinine of 3 is not a good thing. That's assuming 3 means your creatinine.
Probably, I don't know, because remember, I'm new to it, so I'm not fully 100% aware
blood
now.
test that was 3, or the urine, or you're not sure?
Was the biopsy result, something with the biopsy results?
Oh, maybe that you have a class 3 lupus. That may be what the 3 represents.
Oh.
So it may be that you have a class, because lupus is classified into different classes. 1, 2, 3, 4, 5, as I spoke about earlier. So the 3 probably represents that you have a class 3 lupus.
So is that good or bad, the class 3?
Well, again, I can't just answer that by you telling me it's a class 3. So there's a common misconception as well that a class 3 is better than a class 4. That is not exactly true. There's a lot of things in your biopsy besides just saying it's a class 3 that will tell me if your disease is aggressive or not. And I can't tell you that by you just telling me that it's a class 3. If you tell me it's a class 5, I can probably tell you you're good to go, or you don't have to be too concerned, because a class 5 generally is, kind of not too bad. But if you have a class 3 or a class 4, then there's things that we look at within that biopsy that could tell us how bad your disease is. And I can't tell you that by just knowing it's a class 3 or knowing it's a class 4.
Yeah, well, probably I had the 100% information, because all these kind of things that's be like,
I have a feeling that it was what they told you was that it's a class 3, not that your creatinine is 3. If your creatinine is 3, that's not good.
No, because they didn't make it, from what the doctor said, he didn't make it sound like like, I'm at a bad place. He just make it sound like, once I start the salsa, because I put my the salsa,
Mm-hmm.
and that's what I take. And now this is my third week on the salsa,
Yes.
and I ain't really have no side effect, the upset stomach, no nothing. What I noticed is that I'm starting to get a lot of vision problem right now. My vision, is not where it used to be. I
Are
don't
you
know if,
taking Plaquenil?
yeah,
Have
I've
you
been
screened
taking.
your eyes?
They had screen it in the beginning when I started.
You have to screen your
Um,
eyes every year. Every year. Every year. Plaquenil could cause a rare side effect that could affect your eyes.
Yes.
and it's
Or,
starting to affect mine.
or it
Yeah.
may be that you have a cataract or something from steroids or something, but you need to get that assessed.
Well, my next appointment is in December this year. It was supposed to be February, but the day when I had the appointment, I got up and I had flares and I couldn't walk and stuff. So I missed that appointment. And when I went for a new appointment, they gave me December, quite December. So I was wondering if I might have to go private and do it private to see what's going on instead of waiting for the hospital
If
appointment.
you're having visual problems, my advice to you is go and get it assessed.
Okay. All right. Thank you.
Yeah,
Thanks,
no problem.
Alana. Thank you very much for that.
Okay. You're welcome. Okay.
Dr. Lynch, I believe this is one of your patients who's saying, Dr. Lynch, would you prefer a patient who has been on dialysis for 1 year and also suffers from lupus? Would you prefer if they get a living donor or a dead donor?
So a living donor transplant is always a superior outcome, simply because of and then I would modify that statement with the Trinidad situation. But if you look at data, a living donor transplant is a better organ. Why? Because it's a controlled environment. We set a date for the surgery. We usually a living donor is somebody who is very young, well, fit, what have you. We take the kidney out, we go and have a coffee, we come back, we put the kidney in. A deceased donor situation, generally speaking, is not straightforward like that, especially in big countries. You may have to take a jet, like in Ontario, for instance. You take a jet from Toronto, go up in Northern Ontario, 3-4 hours away to procure organ. You have to put that organ on ice. So it has a certain, what we call cold ischemia time. It's on ice, and then you bring it back and you put it into somebody, and it may not work immediately because it's been on ice. So generally speaking, living donor transplant is generally a better organ. However, the Trinidad situation is a bit different. One, we're a very small country. We don't have to go 4 hours up in a jet somewhere in Northern Ontario, close to the Arctic Circle. Two, because of the type of patients, because we don't put everybody in ICU, that's the truth. We tend to put young people in ICU, so we tend to get very young donors. And the best thing about a donor is donor age. If you get a 25-year-old kidney, you are getting a Lamborghini of a kidney, right? So in our situation, if you look at our data, there's not much difference between our deceased donor and our living donor transplants, because unlike in North America, where people will take kidneys from 50-year-olds or even older individuals and give it to older individuals, because of our bias, our selection bias of who we put into the ICUs, we get young kidneys that work fantastically well.
Okay. This is a question. I think the person would like to come see you privately, so they would like to know where your office is. If you
I don't want to do any shameless self-promotion on air. So, I could give you the number after and they could message you.
Great, wonderful. So the other question here is, it's a personal question, but it has to do with sex. The person says that, they are on dialysis, and they feel that they're being pressured. They're being pressured by their spouse to perform, but they can't, and they want to know how to navigate that. Any advice from
Is this a man or woman? This is a man or a woman?
It came up as a private message.
Well, I need to know if it's a man or if it's a woman, because
I don't know. It just says the name of the phone. So
it's hard to answer. It's hard to answer that question not knowing if it's a man or a woman.
But it's that sounded like a man.
It probably is. So this is not, if it's probably a man, and sexual issues on dialysis patients among men are not uncommon. In fact, they're quite common.
Yes.
But we tend not to want to talk about it because of our sort of society and machoism and men being sort of feeling scared, afraid, ashamed to bring up these issues.
Yes.
Because a lot of times it's because of, the issues with sexual performance in men has to do with blood flow to the penis. And a lot of times dialysis and all these things, they cause a lot of calcium buildup in the blood vessels, and you have poor blood flow to the periphery and poor blood flow to the organs. To cut a long story short, the real treatment of all of this is a transplant. The real treatment of any problem of dialysis is a transplant. But these patients, a lot of times, if they're having sexual performance issues, once there's no reason that I can't, I would give them drugs like Viagra or Cialis or something. It does work. In fact, a lot of my patients after would thank me and be very happy after I've given them medications like this, because they do have issues with sexual performance and patients on dialysis.
Right. And does it also affect women who are being, who are dialyzing?
Interestingly, I don't know. I've never had a woman tell me that, but it may well be. I just really don't know. I've never had that experience with a woman speaking about that.
Yes. During our educational series, I'm hoping to get a sexologist to come on board and just talk about, intimacy, sex in chronic illnesses, because I feel that conversation needs to happen, because
it has to happen.
It has to happen. And, going forward, I think, even though we might have laughed a little bit and thinking about it's a gentleman asking that question, we have found, and also trying to assist a lot of patients, a lot of women come forward saying that their spouse, their husbands, boyfriends have left them because of illness. And it's something that needs to really be discussed, and coping mechanisms, because one of the questions I wanted to ask you was, what are some of the coping strategies, lupus patients who have just been given a diagnosis of lupus nephritis, what are some of the coping strategies do you think they can implement and to help them with their mental well-being?
That's a tough question.
Yes.
I think, part of the clinic setting, even though I see patients, I often don't have the time. Really, we should have half an hour, 45 minutes consultation time for patients. We just don't have that.
Yes.
So we often will be quite good to tell them about the medical diagnosis, what you need to do, this is that. But sometimes we don't think about, hey, this is somebody and they have emotional aspects and an emotional issue as well. They've just been given a diagnosis that they probably don't understand a lot. And I'm just telling them this, and I'm telling them they have to take this drug. I think we failed, actually, to be honest with you.
Yeah.
But for me, that's where the allied services come in. I don't see that as my role really as a doctor, and not because I don't see it as being important, but because I'm not very well trained. We're not trained in that really, but there are people who are trained in that. People like medical social workers, for instance, where I trained, every clinic, you had a social worker. So it's not only issues, they deal with not only emotional issues, they can deal with issues with access to government programs and help with grants, because all these things are important. People lose their jobs, all these sort of things. And we don't have that. It's like you just come to the clinic, you see the doctor, you're gone. So we used to have that kind of multidisciplinary approach where we had the pharmacist there, the doctor there, you had your own specific nurse, and you had the medical social worker. The medical social worker was like so much the most important personal liaison. We even had a spiritual person. We had a spiritual person in our unit. So it was that multidisciplinary approach that gave the patient that fulfillment, because it's not just about disease. Disease is one aspect of life, and I don't know if I answered the question, but it's difficult for me to say it because I'm not trained in coping mechanisms. Maybe psychiatrists are as part of their subspecialty training, but that's a bit of a taboo situation as well in Trinidad.
Well, next week we're supposed to have a clinical therapist, Monique Mata. She is going to do a session with us next week discussing mental.
I was about to say that. So I don't think people necessarily need to say, okay, psychiatrist, but you know, someone, a counselor, a social worker, those people are terribly lacking within our healthcare system. Terribly, terribly, terribly.
Very much so. Well, I see that Anastasia rejoined. Anastasia, you can feel free to ask Dr. Lynch your concern with regards to your medication and changing the treatment plan that you're currently on. You can unmute your mic, please. Thank you. Not
Hello.
hearing. Yes, my dear, we're hearing you loud and clear.
Hello?
Right, great. Good night.
Good.
I've been diagnosed with lupus for about 2 years, with lupus nephritis. So I've been on CellCept for a while. So what they are looking at, I think they want to do the biopsy. I just haven't been able to afford to do it just as yet. But they are interested in doing the cyclophosphamide, and I'm just a little concerned in terms of side effects and how it would affect me in terms of work and all of the other things that go with it, because I am a mother of 2 very small ones. So I'm looking at how it would affect both physically and I guess all the other areas that it would affect.
Okay. So again, these are difficult questions to answer without all the clinical information, but I can say this.
Well, I know I had, I think my protein, because I have proteinuria, was pretty high. It was at 7 at one point. I think it's down to 5. I haven't been tested recently, so I'm not sure if it's gone down any further.
Right.
So
for me, the only reason to switch somebody who is on CellCept to cyclophosphamide is if it's deemed that they are not responding to the CellCept. Yeah.
Yeah.
So
well, they've been looking. I've been on CellCept for a good little while. I was intermittent at one point because I wasn't getting it.
Right.
And then, but since I've moved back to Trinidad, I've been getting it and I've been on it. I'm currently on like 3 grams.
I'm sorry, how much?
3
grams. Well, that's quite a dose.
Yeah.
So
that's only recent in probably the last 2 months that they would have upped it. So I was on 2 for a pretty long while.
Yeah. So for me, the only reason, as I said, to switch from the CellCept to cyclophosphamide is if they've deemed that you're not responding to the therapy, either that your proteinuria is not going down a lot or significantly in a certain period of time, and therefore they've deemed that it's a sort of treatment failure. That would be the only reason to switch to cyclophosphamide. That being said, usually what we will do is give people 6 months of IV cyclophosphamide. And then after that, we tend to put them back either on CellCept or on azathioprine, oftentimes more so CellCept. So it's just to give that cyclophosphamide to sort of get that inflammation down a bit better. But that would be the only reason I would see to switch you from one to the other. That's usually the reason.
I know you said that diarrhea seems to be a concern with CellCept. Strangely enough, I seem to have the opposite problem. So,
well, you're lucky. Because lots of people have bad diarrhea with CellCept.
I actually have the complete opposite. I have lots of constipation issues with it. I don't know if it's that or if it's other medication that I'm taking as well.
It's probably not the CellCept that's causing that.
Okay. Well, that's good to know, because it was one of my greater concerns as well. So
it's unlikely.
Thank you for the information.
No problem.
My concern, as I said, was only what the side effects with the cyclophosphamide would be.
Right. So
how it would affect me.
So cyclophosphamide is like chemotherapy. That's what it was used for originally. No, again, the dose we use it at is not the doses they would use for chemotherapy. We use far lower doses. Major side effect of cyclophosphamide rarely is that it could long-term lead to cancers. However, let me say this, it depends on how much you get, okay? So 6 grams, which is a gram a month for 6 months, is not going to do that. If you look at where the cutoff point is about 28 grams. And not an absolute, it's just a risk. The other thing, particularly in women, is that it could affect your fertility, and therefore it could destroy your
Yeah, that it
fertility
could
and
affect.
your egg. Sorry,
I didn't hear that. It could affect
your fertility,
in women.
right?
Oh,
So if
well, I
you are
don't plan
planning
on
to
it.
have children, then being on cyclophosphamide,
Uh-huh.
you have to have that discussion. Now, that being said, as I tell people, yes, it may do that, but being on dialysis certainly affects your fertility even more. And CellCep, you cannot become pregnant on CellCep because CellCep is teratogenic. It could damage the baby. So it's okay to say, oh, I'm not taking cyclophosphamide because, but the alternatives are also have issues with fertility. So those are the two issues
Yeah.
that are unique to cyclophosphamide. It increases your risk of infection.
Just now, Brent, just now.
It increases your risk of
Yeah.
infections. So does CellCep. In fact, there's this myth that cyclophosphamide is worse for infections than CellCep. That actually hasn't been shown in clinical trials. So they equally cause infections. If anything, CellCep cause a bit more. So both of them have that risk. But the things that are unique to cyclophosphamide is the long-term risk of malignancy or cancers, but that is with a lot of cyclophosphamide. That's why you start to think when you're giving people cyclophosphamide, when you're giving them repeated courses, you start to calculate the dose and how much you're giving them, because that becomes an issue, and also the issue with fertility.
Dr.
Okay,
Lynch,
thank you.
Dr. Lynch, there are two types of dialysis, is two techniques. Can you talk
Yes.
about
So there is hemodialysis, which is blood dialysis, which most people are familiar with, where you come, we take your blood, we pass it with the aid of a machine through a filter, and we give it to you back. That's what it is. We clean out your blood with an external filter. There's also something called peritoneal dialysis, where we use a natural filter, which is the peritoneum, within the stomach or the abdomen. So we can put a tube in there, called a catheter, and then we can put quote unquote clean fluid in. So we put clean fluid within the belly, and all the bad stuff from in the blood comes out into that fluid, and all the good stuff from the fluid goes into the blood, and then we drain that fluid. And by doing that repeatedly, we can also quote unquote clean the blood using that technique, and that's called peritoneal dialysis. They're both equally effective. No one is better than the other, except that for peritoneal dialysis, you have to do it yourself. So we teach you, and you do it yourself at home. So people who are self-motivated, who enjoy their independence, it's a great form of therapy because you don't have to go to a center 3 times a week, drive for an hour in traffic, wait for a half hour to an hour to go on the machine, sometimes come off the machine and wait for your fistula to stop bleeding. Your nut might be feeling well, go back home in traffic, you waste your day. It's done. 7 hours, you're gone there already, and you're doing that 3 times a week. Whereas peritoneal dialysis, you can just stay home, do it. Usually now, most people do what is called cycler dialysis. So we have a little machine, and they actually use that machine to do it at night while they sleep.
Yes.
Yeah, and then they will carry along a bit of fluid during the day. So it's equally effective as hemodialysis. It's not inferior. There's all sorts of myths about PD and it get infected and all this sort of thing. But guess what? The worst infections I've seen is dialysis catheter infections. Dialysis catheter infections are the worst infections I've ever seen of all infections in my entire medical career. So and to be honest with you, the risk of infections or peritonitis from peritoneal dialysis, I can't even remember the last one we've had. It's gone down significantly simply because we teach patients well, and it's really a technique of hand washing. Once you wash your hands well, because that's where usually the infection will take place when you're doing your connections if your hands are dirty. So once you take your proper hygiene, everybody's washing their hands well now with COVID, the risk of infection is very low.
Someone is asking about exercise. Can they exercise and maintain some level of fitness, being on dialysis?
Of course, there's no limitation to exercise. You exercise to your limit. That's what I tell patients.
So it is recommended. Someone with lupus nephritis.
Of course, exercise is recommended in everything. Always good. No, don't go push yourself and try to run an Ironman or some sort of thing. All right. So you exercise within your limit of tolerability.
Right, right. Well, I mean, thanks to steroids, I feel like Shira. So I like the burning and pumping iron, but then there's some days when fibromyalgia takes in, I can't even lift it. Last question. I see, Justin, you raised your hands. I know you would have asked Doctor. I did ask the question. I'm not sure if you would have heard his response, but you can unmute your mic and feel free to ask him, just for you to be satisfied thoroughly that you got your question answered.
Good evening, Dr. Lynch.
Yes.
Hello, good evening.
Yeah, I'm here.
We're hearing you.
Yeah, I'm one of your patients. My name is Juste Guerra. I'm the person who has been getting me daily headaches. It started since May, middle of May. It was getting better a bit after my exams when I did them in July. And last week, they came back every single day, except for maybe one day within the past week and a half. And I wanted to know, should I come see you, or would I need to see another?
I think you need to be assessed usually with that. If you're having daily headaches, I usually send patients to see the neurologist. If there's nothing obvious to me, I mean, sometimes there's obvious stuff. Sometimes it may just be a drug effect, or if you're on like amlodipine. Are you on amlodipine? I think you're on amlodipine, aren't you?
No, I'm only on Celcept. I came off prednisolone about 2 weeks ago.
Right. So it may be a drug effect. If well, it's not Celcept. So if it's just that, it's not. So therefore, I would usually send patients to the ophthalmologist, to the neurologist. They could look at your eyes to see if there's, we look at the back of the eye sometimes to see if there may be increased fluid around the brain and all that sort of stuff. They may do a CT scan, that sort of thing. But daily headaches, that's something that is not. I think that's concerning a bit there actually.
Okay. I didn't hear everything properly. Should I make an appointment to see you first, or should I see a neurologist?
You could come and see me, and I will see what's going on and see if it may be a simple issue that I could deal with. And if not, I'm going to send you to the neurologist. That's usually what I would do.
Okay, I don't have an appointment at Mount Hope anytime soon. Should I come see you privately, or should I come to Mount Hope?
You can make that decision, Justin, whichever one you feel comfortable with. Problem with Mount Hope is that I can't control that clinic. Problem with Mount Hope is that I used to have a clinic with 50 patients in it when I had staff, and now they've cut my staff. I really only have one doctor that I worked with. I've written numerous letters about that, and they tell me take it or leave it. So, and they told, I'm serious, that's literally what they said. And so I had to, I mean, I can't see 50 patients with an inexperienced one house officer. So we can't be there till 3 o'clock from 8 o'clock. That's unfair. So what I've been forced to do is to cut the numbers. That's the truth. So what has happened is when you cut the numbers, then everybody gets pushed down the road. And I don't have control over that. That's the problem. So that is what has happened since the last year, since I took over transplant. Really, that happened with my nephrology clinic. And all I told them was, give me some more staff and we'll be okay. And anyway, I don't want to get into that. So that's what happened. So unfortunately, I was forced to cut my clinic numbers. So people would just push down the line, and that's why appointments have been like how they have been.
Okay, thank you very much. I will ensure that I see about it as soon as possible.
No problem.
Okay. Last question. This is a lupus patient saying, I recently had a biopsy done. I'm awaiting the results. In the meantime, I was told to continue with a normal diet, but I took it upon myself to stop eating most things containing salt and sugar. Since then, I've noticed all swelling going down, and the dipstick is now reading 2+. Right. What else diet-wise can I do to keep in good health with the suspected lupus nephritis in the meantime?
So salt is what drives the fluid retention, as I tell people. So one of the strategies to reduce swelling is reducing sodium intake. interestingly enough, salt also drives proteinuria. So reducing salt also reduces protein in the urine. Now, if you have 10 grams of protein, it's not going to reduce it significantly. But if you have 2 grams of protein, reducing salt could reduce that to about 1 gram, 1.5 grams. So it does have an effect, particularly at the lower ends. So it's not surprising that that has happened. By reducing the salt in the urine, the salt in the diet, your swelling goes down and your protein will go down a little bit. Apart from that, I mean, if with all the clinical information, I wouldn't really say there's absolutely anything else that's really necessary from a diet perspective. I mean, we all know what a healthy diet is. I mean, you shouldn't be having hamburgers every day and that sort of stuff. You should try to have a balanced diet, have more green stuff, more, you know, not off the grill fast food, more cooked food, less sodium. I mean, we know that, less fat, less saturated fat, butter, all that stuff. So apart from having a healthy diet, the only thing, generally, which I would recommend to everybody who have lupus, don't have anything. The specific things that I always say is reduction of sodium. And I say, we often tell patients salt, and patients will come and say, doc, but I'm not taking any salt. And that's true. They're not adding any table salt, which is sodium chloride. But there are other forms of sodium which have the same effect. So sodium benzoate, which you find in ketchup and preservatives, sodium nitrate, which you find in preserved foods, all those things have the same effect as adding salt. Not to mention that if you actually look at the sodium content in food, you look at bread from Kiss, and you will see how much sodium there is in a slice of bread. Anything in a can, forget about it. It's all sodium. So they may not be adding table salt and cooking with table salt, but they are still taking in a large amount of sodium from these other sources.
Excellent point. Well, guys, we've come to the end. Unless you have another question, we just want to say, Dr. Lynch, thank you for your time. There's no amount of money we can pay you for this. Your time, so priceless. Thank you so much for going in detail and just fielding the questions. Not forgetting, Tobago is in the house. I don't know if our patient in Tobago has any questions. You know, nothing finished. All right, good, wonderful. All right, wonderful. All right, so guys, we have officially come to the end of yet another series, another webinar hosted by the Voice of Lupus Foundation. Today we discussed lupus and the kidneys, and it was facilitated by, you know, the esteemed Dr. Shaun Lynch. So want to say thank you again for all those who joined in via Facebook, and of course, those who would have logged in via Zoom. And of course, if you are interested in seeing Dr. Lynch privately because you believe you have some sort of involvement with your kidneys with the lupus, please send me a message and he will pass on the information to me and I'll send it off to you. So again, Dr. Lynch, thank you very much. Do you have any closing remarks? I mean, I hope you think, you know, I hope honestly that this session and these series that we have been spearheading is really going to have an impact. There's a lot of topics that is not...
I really hope so. Listen, this is my passion, and honestly, I want patients to start advocating and insisting for themselves. You know, I see patients and they're lupus and they haven't had a kidney biopsy, and and I'm like, what is going on here? You know, and patients must start getting that information.
Yeah.
Must start, because you know, a lot of times I see a lot of substandard treatment, and that gets me really angry. So it does really get me angry. So, you know, if as I said, if one person has been impacted and informed, that's good enough for me. Because I don't like to see failures. I don't like to see people fall through the cracks simply because of slackness, really.
Yeah.
So we really have to, if this educational program for the patients is going to help, insist that you get your protein quantified. This dipstick thing with 1+ and 2+, that's not good enough. You need to know how much milligrams of protein. You need to know the trend. Is it going down? How is it going, doc? Is it getting better? That's all we manage. What does my biopsy show? What class? Is it a lot of inflammation? Those are important questions to ask, and that's important information to get, because it's not only about what is now, it is what is likely to happen in the future, your prognosis. And a lot of that, we can't predict the future with 100% certainty, but we can guess based on certain factors that we see now. Hey, listen, this is looking bad. We need to be aggressive. That's all. And gets the patient mentally prepared, when I see that some patients I see and they have a class 5 lupus, and me just telling them, hey, if I have to get lupus in the kidney, I'll take a class 5, and they'll be like happy because your prognosis is much better, that sort of thing. Those little things, it makes them, less anxious, more settled, that sort of thing. So we need to get it right.
Well, I'm happy to have you on board, and I look forward for us working more to create change and to really make a dent in this. So thank you again for your time. I wish you a good night. I know the kids are probably waiting for the bedtime story. They want daddy to come and tuck them in. So I'm sure they're probably waiting there. They know daddy's on a call. So let me let you go to the family. Again, thank you. So coming to you live from here in New York to over to you in Trinidad. Thank you for being part of this. I'm so happy that we were able to get the session ticked off. I'm so happy. So again, thank you again. Good night.
Good night.